So welcome everyone. I'm happy to introduce you to another webinar hosted by the EANS section. And this time we have a special webinar. We have the leading authors of a landmark trial, of the PENS trial, an RCT in neurosurgery and neurology, a rare event. And I'm happy to hand over to Mats Tullberg and Giorgio Palandi to introduce our current speakers today. So enjoy.
We cannot hear you, Mats.
No?
Yeah.
Yeah, sorry for that. So it's my pleasure to welcome you to this webinar, and we are very excited to hear this talk. Today we will focus on the PENS trial of efficacy of shunt surgery in idiopathic normal pressure hydrocephalus. We have two distinguished speakers, two of the main authors of this study, and it's a pleasure for me to introduce them. And I will co-chair this session together with Giorgio Palandi, whom you are well known with and know well, I think. So our two speakers today are invited. It's Mark Hamilton, Professor of Neurosurgery, Cumming School of Medicine, University of Calgary in Canada, and together with Professor Michael Williams, is the Professor of Neurology and Neurological Surgery at the University of Washington School of Medicine in Seattle, USA. They will report from the trial, and this study was published in September. They will take turns on their talks, and after their talks we will have some time for discussion, and we hope you are willing to participate, and please post your questions in the Q&A form at Zoom. So before we set off, I would like just to give you a short introduction about the importance of this study. So as you are probably well aware of, randomized controlled trials represent the gold standard in clinical research and evidence-based medicine. And these trials are specifically designed to minimize errors that makes us draw wrong conclusions from studies that also may. And within the community of iNPH or NPH, we are well aware of the fact that shunting is a good and effective treatment in NPH, I would say. But outside of the community, both the diagnosis and the efficacy of our treatment are still questioned. And this skepticism represents a significant barrier to scientific progress and a broader recognition of an iNPH as a common yet treatable condition in the elderly. And earlier, very few randomized controlled trials have been published in iNPH, and this is a real weakness. And in the work with the iNPH guidelines that is ongoing, it is very evident that we lack studies like these in many areas. So these results that will have been presented and that you will hear about now, we believe will have a major importance for the future progress of iNPH research, and also the progress and implementation of new guidelines that may make the worldwide acknowledgement of this disorder grow by large. So having said this, I would like to introduce Professor Mark Hamilton and Mike Williams to tell us about the study, how it was done, what you found, and things that you think we should discuss maybe. So please, Mark, I know you will start.
Thanks. Can you see my slide? Great, thank you. Thanks, Matt. Thanks, Giorgio. Thanks, Dr. Becker. Thank you, everybody, for allowing us the opportunity to talk about this trial. It's a pleasure to engage in conversation with people who are interested and passionate. I have a variety of disclosures. Most of them deal with working with nonprofits and patient associations. So what are we going to do today? So Dr. Williams and I are going to segue back and forth. So I'm going to do a brief overview of what went wrong after the discovery. I'm going to talk a bit about the guidelines and how that changed things. I'm going to then introduce the PENS trial. And then Dr. Williams is going to talk about the results of the PENS trial. Excuse me, I'm going to talk about some of the complications and some brief reflections from a neurosurgeon. And then Dr. Williams is going to do a neurologist reflection. So the background, we're all familiar with this. 1965, Solomon and Keene, New England Journal. Things went a little crazy after that. Results were poor. Patient selection was poor. Outcomes were poor. And so skepticism became the big issue. So what went wrong? Well, lots of things, but what is NPH? In other words, one of the things that went wrong is people weren't really clear about what kind of patient we were looking for. And although you may or may not agree with the term or the name NPH, I think the way was used in the past, NPH incorporated a lot of different entities, and I'll show you that in a minute. But I think of NPH as a very non-specific term meaning clinical features. It can be a number of different disorders. Ventriculomegaly occurs, of course, as you can't have NPH or iNPH if you don't have big ventricles. And atrophy and other disorders can cause that. And then when we come to iNPH, it's really referring to this group of patients aged 60 years or greater with new onset ventriculomegaly, so new onset. They don't have a precipitating cause, etiology. And that's the subset. And when you look at the literature, it's a bit mucky. So this is what the Adult Hydrocephalus Clinical Research Network uses to think about the different types of adult hydrocephalus. So the transitional is pretty straightforward. You're treated as a child. Unrecognized congenital has many different names. Acquired, it seems pretty obvious. And then there's iNPH. I think a lot of the literature in the past, partly because of the international guidelines included patients 40 years and above, became very messy. So what happened? And research advances happened. Specialty centers developed. Guidelines were developed. If you look at this PubMed search, just on the terms iNPH or NPH and hydrocephalus, you can see the number of manuscripts on a yearly basis increasing, exponentially. We have guidelines that are available. The Japanese Hydrocephalus Society, they have 3 sets of guidelines. Their national guidelines are a bit old. I'll mention briefly at the end that they're undergoing revision and some of the challenges with that. American Academy of Neurology has abbreviated practice guidelines, and there are a lot of different guidelines in different countries that are region-specific. Now, this is sort of basic for all of us, but what do you do to diagnose a patient? What's the diagnostic process? So the main things are clinical symptoms, radiology, and physiologic testing. Now, at this point in time, clinical symptoms and radiology are not specific enough for the majority of patients, and we can talk about that particular emphasis to select patients at this time. Physiologic testing with lumbar puncture, lumbar drain, or dynamic testing has been very helpful. The usual process, you have symptoms, you have imaging, clinical diagnosis, clinical assessment rather. Differential diagnosis is extremely important. You need to do basic tests that you can measure before and after lumbar puncture, lumbar drain. So gait, there's a variety of different ways this is done. We can talk about that, cognition, and urinary dysfunction. Now, the expected outcomes in specialty centers, not specialty cents, is that all symptoms can improve. I think we work with these patients, we know this. The ultimate degree of improvement depends somewhat on the coexisting disorders and the severity of the injury to the brain caused by hydrocephalus. So a severely injured patient with iNPH has less probability of improving dramatically. And long-term improvement is possible for most if shunt function is maintained. Now, we believe this, but there's still a big perception problem. And small numbers of patients are getting access to treatment. So what are we going to do about this? And neurologists and neurosurgeons, I think, had enough equipoise to say that an RCT was needed, a randomized controlled trial. Big question was how to do it in a safe and ethical way. And it got to the point where a non-eloquent, that's the way I phrase it, moratorium was called on for shunt surgery. I think that was a bit over the top. But there was definite evidence that people were willing to go ahead with this. Now, there are many well-done randomized clinical studies, and that's our experience, and we know that. There are also a lot of studies that aren't well done. For randomized trials, the Cochrane Review identified 3 small sample randomized placebo-controlled trials. Moderate evidence that gait, speed, and disability were improved, but really said that you needed to do a bigger study. So that's the PENS trial. Now, the PENS trial, work on it started a long time ago. In 2007, 2008, Dr. Williams and Dr. Mom, and then Dr. Luciano, and then eventually myself, over time, helped develop that in conjunction with the Adult Hydrocephalus Clinical Research Network. We did a pilot study, which showed we could do it, and I'll explain how. That leads us to what we have now, a placebo-controlled effectiveness and iNPH shunting trial, the PENS trial. It's international, multi-center, prospective, double-blind, randomized, placebo-controlled. That's a hard thing to get in surgery. And a sample size that was sufficient. And it was published in New England Journal in September online. And there's a lot of people that were involved in this trial. These are some of the sites, and the blue sites are where we identified, those were AHCRN sites as well. So over 20 sites. Now, this is extremely important, that the intervention was, and the outcome were not whether you had surgery or not. All participants had shunt surgery, and I'll show you the protocol pathway in a moment. So the intervention was the initial shunt setting. So we had the advantage of having a valve that had a virtual off. So we could adjust the resistance without the patient knowing what was happening, and have that valve set at a very high setting. And if you look to the right, you see this is a bench study that was done from the Certus valve. And these are the settings, going up to 7. And then from 7 to 8 is a big jump, and the resistance is about 500 millimeters of water. Now that is really high for an patient with iNPH, and they don't drain. And so we had a placebo group that were randomized to a setting of 8, an open shunt group, a setting of 4, and the primary outcome was gait velocity. The primary endpoint was 3 months for gait velocity. And then at that point, in a blinded fashion, all the shunts were open, and the study continues through to 12 months of active shunting. So how do we select patients? We had an N of 100. We basically selected them with the international guidelines, but we wanted them to be able to walk fast enough that they could do a 10-meter walk, so that they had to at least be able to do that, and not so fast that it was hard to discern a significant change. And we waited after those tests, lumbar drain or lumbar drain, at least 4 weeks, usually longer, before we went for baseline assessments and then shunt surgery. And they were randomized just before surgery. Primary outcome measure I mentioned. We had standard methodology, which Dr. Williams would probably talk about. And we did exclude, as I mentioned, people who couldn't walk, people who walked a little too fast, secondary NPH, previous cranial surgery, anticoagulation. And comorbidities, we allowed a lot of comorbidities, but they just had to be such they didn't interfere with the assessments. Now, this is a bit of a disturbing flow diagram, so I'm going to simplify this. This was the protocol and how patients progressed. So the symptoms and imaging were assessed according to the international guidelines. We all know that. Positive TAP test or ELD with no exclusion criteria. If they consented to randomization, if they consented to the study and they were randomized to either open or placebo. And then at 3 months, there was a primary outcome measure. And we measured all of the various parameters, but the primary outcome measure being looked for significance was gait velocity. And then evaluations are continuing for 9 and 12 months. So they're actually getting 12 months of active shunting. These are the outcomes. So just before I hand this over to Dr. Williams, I'll just tell you some of the things we collected. There are also secondary outcomes, MoCA, Chinetti, bladder outcome score, STMT, a variety of different NIH tests, depression inventory, Lawton, modified Rankin, quality of life, and complex imaging very comprehensive imaging with 3T MR. We can look at ventricular volume. There's a lot of things to come, and Dr. Williams will talk more about that. So I'll pass it on to Dr. Williams, and I will stop the share as soon as I can figure where my screen went. Okay. Still. Oh, there it is. Okay. There you go, Mike.
All right, here we go. Good morning from the west coast of the United States. I know that's evening in Europe. Yeah, and I'm really happy and pleased to be able to join you for this presentation. So my name is Mike Williams. I am a neurologist by training, although I have worked closely with neurosurgeons for my whole career. I started my career on the East Coast at Johns Hopkins, and I'm toward the end of my career on the West Coast at the University of Washington. These are my disclosures as well for you. And so let me go right into the results of the trial. And this is the consort diagram over here. And as you can see, we evaluated 1,424 patients and eventually came down to just over 300 who were eligible for the study, taking into account the exclusion criteria. 237 of those were approached for consent. And a number that really surprised us was that just over 50% of patients provided their consent to participate in the trial. These are patients who could have said, no, I just want my shunt, instead of taking that 50-50 chance that they might be in the placebo condition for the first 3 months after the shunt surgery was done. And on a personal note, many of them had a hard time getting to us. And when they understood that we were trying to overcome skepticism regarding shunt surgery, they were willing to participate to help us to prove whether or not shunt surgery was really effective. It was a 50-50 randomization. We actually hit that target a year ago in January of 2025. The population is exactly as you would expect for NPH. The mean age is 75. It was roughly 50-50 male and female. The centers were in the United States, Canada, and Umeå in Sweden. So it's mostly a white population, and they're fairly highly educated. The educational attainment is bachelor's degree, and otherwise the groups are quite similar. So this is what I call the money slide. The primary outcome, as Mark said, primary outcome variable was gait velocity. So first, we can show that the two groups were similar at baseline, and the baseline was following the evaluation either with TAP test or ELD. So we had a minimum of 4 weeks for their symptoms to come back before we got this baseline data. And here is the gait velocity change at 3 months. The open shunt improved by 0.23 meters per second. The placebo group essentially had zero change. And that's a treatment difference of 0.21 meters per second. And we were statistically powered to show a difference of at least 0.2 meters per second. So these results, if there's any missing results, those have been imputed, and this is controlled for multiplicity. And here is the histogram of the two groups showing the difference. So the dotted line in the middle is at 0.1 meters per second. That's the minimum clinically important difference for change in gait velocity. And they're virtually mirror images of each other. There's a significant improvement over here for the open shunt group, and actually worsening in the placebo shunt group. And if you just want to know how many improved in either of them, 80% improved above 0.1 meters per second in the open shunt group. Interestingly, and this gets to the question of whether or not there's a placebo effect, 24% improved in the placebo group. If we look at some of the other differences, the Tinetti is a standardized gait scale that's been around for more than 40 years. It's highly validated. It looks both at balance and at gait. I particularly like it because it's good for neurologic gait disorders. And the placebo group had essentially zero change, half a point. The total number of points on the Tinetti is 28, and the open shunt group improved by 2.9 points. The MoCA, regrettably, did not improve, at least not by a statistically significant difference. And part of that is because we controlled these variables for multiplicity. If you didn't do that, then you would have p-values that looked significant. And we'll get back to that in a minute, because when you submit something to the New England Journal of Medicine, they're very, very picky about the statistics. So the next is basic imaging. So here's the Evans ratio, and there's no surprise that there's no difference in the Evans ratio between the groups. And even though you might argue that there's some significant difference over here, in fact, nobody can tell a difference of 0.02 on an Evans ratio. But what really matters is the change in ventricular volume. So in the placebo group, at the 3 months time point, there was 4.4 less milliliters in the ventricles, but significantly less in the open shunt group. And what that really suggests is that the placebo is doing what you want the placebo to do, that the shunt is effectively off for the placebo group. These are the tertiary outcomes over here. And these are showing just the mean and the confidence intervals. So we're not showing the statistical significance. And again, the missing results are imputed, although there aren't very many missing results. But what you see here is a trend. Almost everything is better, favorable for open shunt, whether it's the SDMT, which is a measure of processing speed, the same for the NIH flanker. The EQ-VAS, the quality of life, is significantly different between the two groups. In fact, it was less in the placebo group at 3 months and better in the open shunt group. And then the Lawton is a way to look at ADLs. But I want to bring you into the modified Rankin scale, because this is an outcome that's used in lots of different neurological and neurosurgical studies. A few have done that in hydrocephalus. And we grouped them by the proportion that had scores 0, 1, and 2, which is a common way of dichotomizing the MRS. And the placebo group is down here. And you can see from baseline to 3 months, there's essentially no change in the 0, 1, and 2. But there is a shift in the other groups. You're seeing more patients who are in Rankin score 4 than there were before. The open shunt group does exactly the opposite. So we see a significant increase in the proportion of patients who are 0, 1, and 2. And then if you look at the lower scores, we no longer have patients at grade 4. So that's a really significant difference. So what does this mean? It means, first of all, that VP shunt surgery is effective and iNPH is real. This is a clinically meaningful improvement in gait velocity, and there are actually fewer falls in those 3 months. And I didn't show that data. The ventricular volume is diminished, so it's all consistent with a functioning shunt. The placebo group had no change in gait velocity, and they had more falls, and their secondary and tertiary scores were unchanged or worse. And what that means is that iNPH is real, and patients should be identified and treated. Gait velocity as a marker of health in the elderly, and there's been some people who have tried to debate with us whether the gait velocity is meaningful, but if you consider NPH to be a gait apraxia, patients with gait apraxia are slow. But if you look at the geriatric population data on falling, patients who are very slow have a much higher risk of falling than patients whose velocity is greater than 1.1 meters per second. And the lower limit of normal is about 1. So the combination of being faster and having fewer falls is what's really important about these outcomes at 3 months. And the number needed to treat to achieve that change of 0.1 meters per second, the MCID, is 1.79. That's pretty powerful. There are some complications, and Mark's going to get to that in a minute. The strengths of the study are the blinded design, the statistical power, and the quality control. So you have to think about how generalizable is it? Well, first of all, this is only iNPH, not the other forms of hydrocephalus that Mark mentioned before. It's applicable only to patients selected on the basis of TAP test or ELD, and only applicable to patients who at baseline could walk independently, whether they used an assistive device or not. But if they needed assistance from another person, they weren't allowed into the study. All of the sites used the international guidelines. They had their variations on that. And we would expect similar outcomes with other adjustable shunt valves. So we can't make a recommendation regarding any shunt maker model. The main reason we use the Certus Plus is its ability to give us the placebo condition at setting 8. There are future outcomes that Mark hinted at. We're finally starting to see those results, but it's too soon to report on them. So I'm going to give back to Mark at this point.
Thanks, Mike. Let's share again. So just going to talk about the adverse events in the trial. So falls, very important. The open shunt group did have falls, but they were substantially lower than in the placebo group. And that, again, implies that the shunt was having a meaningful effect on gait and balance. Clinically significant falls, we had definitions for those. There was 1 in the open group and 3 in the placebo group, not statistically significant. Positional headaches, the open shunt group, 55%, in the placebo group, 30%. So headaches occur in patients who are shunted but don't have an open shunt. Something to think about as we move forward. And then we had to do off-protocol adjustments. The open shunt group, they usually were raised because of those symptoms I mentioned, predominantly headache, or if there was a subdural effusion or subdural hematoma. And the placebo group, some had to be lowered because of deterioration. The serious adverse events, there was definitions again. There's 13 in the open group, 9 in the placebo. Subdural hematomas, of the 6 that occurred, 3 required surgical drainage, and 3 were simply eliminated using valve adjustment. There was 1 death in the placebo group from a parenchymal hemorrhage and complications related to that. 1 additional small parenchymal hemorrhage, and for subdural hygromas, they were all eliminated using valve adjustments. So the complication rates and profiles are similar to previous iNPH trials and lower than rates seen in national surveys, for instance, in the US. Again, we didn't include patients in anticoagulation. We would expect similar outcomes, but as Mike said, we're not trying to endorse this valve. Outcomes with other shunts should be the same, and I'll mention that very briefly in a minute. So just some brief comments about the treatment issues. We had a meaningful effect we had a number needed to treat of 1.79, but this surgery can't be done safely, then there's no way that this is going to be helping patients. And so the ability to generalize this to the population in certain centers has to be very carefully managed. We only have one option for treating these patients. It's a shunt. ETV is not proven to work, and there's no proven medical treatment. So shunts. We all know these shunts. There's mostly these and some others. There's no evidence that at this time that any are better than any other with respect to treatment outcomes. Same thing with valves. But shunt failure is an important issue we need to address because that again affects the patient outcomes. Now this is more than 60 to 70 years ago. The technology has changed, some adverse outcomes. So we all think we must be doing better. So I'm going to show you this result from a paper that Joe Pyatt published. It's looking at a nationwide readmissions database in the United States in 2015. And these are children, elders, adults, infants, reoperation rates, 200 days, 50%. So in the real world, these aren't the results we see in specialty centers. So again, we have to be very careful about generalizability. These are the things that we can look to try and fix. We don't need randomized trials to do this, and that's one of the things that hopefully we'll talk about that. I'm just going to show you, not even showing you the results in a major way, but just that this is a study that we did in our center showing you can reduce shunt failure just using quality improvement methodology. Again, we don't need double-blind randomized trials, and you can reduce the rate of shunt failure. Very importantly, infection. Again, using quality improvement methodology, we should all have infection rates that are very, very low. Simple things that can be done in the OR. We talk about the need for antibiotic impregnated catheters, but that's sort of an iffy thing. And this is in our center where we implemented using a basic protocol, and talk further about that if you wish in a minute. And then we monitored infection, and then we made another change, and the infection came down. And we had, at the time of the reporting, 621 consecutive surgeries. Now we have more than 1,500 with 4 infections. So simple techniques, paying attention to details, can make a big difference. And the guidelines are being redone, international guidelines. And we also are going to be adding a standardization of clinical research methodology and reporting. And why are we doing that? This is just a very simple, brief example. We reviewed a systematic review and meta-analysis of 38,000 adult shunt surgeries. The data was just absolutely horrible. And our work with the current guidelines reevaluation is showing us that. So we need to really work on standardizing how and what we report. And we can't compare results among sensors if we don't have that information. And now I'll turn it back to Mike.
Can you see that okay? Okay, but I'm not getting my slides to move. So let me stop sharing for just a moment and redo this. Sorry about that. All the practice in the world. And try again. All right, here we go. A neurologist's reflections. So the first thing that I want to say, and it's going to sound like I'm boasting a little bit, but I think it's true that the data are trustworthy. We put a lot of thought into the design of this trial because we understood the stakes. And I often said as we were designing and performing this trial that we were putting our careers on the line. Either we were going to show that there's a real response to shunt surgery and iNPH is real, or we were going to show that we were wrong all this time. And so we were very, very careful about the methods. We had quality control. And what that means is that we were actually seeing videos from every center of the gate as they were done. We would receive these after the fact. We didn't use the videos to score, but we gave feedback to all of the centers. And we did the same thing for the neuropsychology testing. So we wanted the best quality evidence that we could get. Next is that all of the patients had shunt surgery. The placebo condition was as close to no CSF drainage as possible. The slide that Mark showed with the opening pressures for the Certus is bench work that we did with UMIA in anticipation of this trial. And we did not play games with the statistics. I mentioned before that the New England Journal is very, very picky about the statistics, and we had to report it exactly as we planned to. What neither Mark nor I have mentioned is that we were all blinded. It was a year ago in January 2025 when the DSMB, the Data Safety Monitoring Board, was meeting, and they came back on the line after seeing the results, and they told us to stop enrollment because there was a clear difference between groups. Well, we actually had achieved by that time, there's an interval between the data they get and the time of the conference. We had achieved 99 patients by that point. So we had no idea until a year ago. So this brings us to the next era of NPH. And this was a viewpoint paper that we were invited to write by JAMA Neurology. In fact, we received that invitation just a week before the results were published in September. And we want to call this new era evidence and engagement. Previously, patients were abandoned. They didn't feel that they had any place to go. And in this paper, we're calling on the community of researchers to build on the evidence of the PENS trial. The PENS isn't the first study to show improvement with shunting. It's the first large-scale placebo-controlled trial to do so. And so if you go back and look at the previous research and look for the best research, we're actually validating that research. But there's more to be done. And I think the biggest question that I've always had as a neurologist is to understand what is the biology behind the symptoms of NPH and the recovery from those symptoms. These are not dead neurons or glia. These are dormant neurons in glia. Something is keeping them from functioning normally, and it comes back very rapidly when we drain CSF. But we also have to call on community physicians to engage with iNPH specialty centers to identify and treat more patients. In community practice, you have the vital role of first contact. You see these patients, and there's going to be a lot of patients who are referred for that question. But if you go through the appropriate evaluation, not everybody initially suspected of iNPH is actually going to have it. And the specialty centers should be available for referral to do additional testing as needed and to select shunt candidates. And then another thing that's very important, and it's going to be shown ultimately in the PENS trial, is that you need longitudinal follow-up. It isn't put a shunt in the patient and wish them good luck. It's put a shunt in the patient and have them come back to make sure they got well as much as expected or to look out for complications. Well, iNPH is really a major population health issue. There's an idea out there that it's a rare disorder, and this is a wonderful epidemiologic study from Mats Tulberg's group in Gothenburg. It's building on some of their previous research, and I think the comparisons that they make in this paper are exceedingly important. The takeaway is that iNPH is as common as Alzheimer's dementia. In their studies, they look at scans. They have data on symptoms, and because this is the first time they could follow a cohort, they could see how many patients converted from asymptomatic to symptomatic. So we not only have incidence, but prevalence. So the incidence is 4.8 per 1,000 person years, and the prevalence doubles over 6 years. And these numbers, 4.8, are comparable to Alzheimer's disease, to vascular dementia, and to Parkinsonism. And yet there's very few centers for NPH compared to all the academic medical centers that have centers for Alzheimer's disease or Parkinsonism. So this is a paradigm shift. Before PENS, clinicians could say, well, I don't believe, so I don't have to work up the patient. We have met the burden of proof with PENS. So I come from a background in biomedical ethics. As a side gig in the past, I used to chair the American Academy of Neurology's Ethics Committee. And I think that clinicians now have a duty of care to meet clinically minimum standards of recognizing the potential symptoms of iNPH and initiating an evaluation, which is really a good clinical examination and imaging to identify and treat the causes. When a patient is sent to us for NPH, it's not just NPH that you're looking for. It's to understand where are their symptoms coming from. And then patients get referred for testing and treatment. I'll go over this quickly so we have time for discussion. But what I do in my clinic is basic clinical neurology. You take a history, you do a thorough examination, and you think through the differential diagnosis of all of the symptoms. Fundamental neurology. And the symptoms of NPH are the gait, the balance, the bladder control, and the cognition. And there are findings that are suggestive of iNPH, but findings that suggest other disorders. So you may want to get additional tests like MRI scans of the spine or EMG. If you're worried about dementia, then DAT scans or dementia biomarkers and so forth, and then eventually referrals to centers of expertise. So I'll stop there. I want to thank you for your kind attention, and Mark and I have time to take questions.
Thank you very much, Mike and Mark. I think your lectures were truly excellent. I want to thank Jürgen Beck for organizing this webinar with us, and of course, Mats Thulberg for co-chairing this with me. And I think we have already some questions for you. The first one I can see is from Ahmed Karagoz. The placebo effect can be related with the CSF drainage in the surgery?
So immediately after surgery, and Mark, you might want to say more, patients may experience transient improvement. But I would expect, and we saw in the patients in the placebo group, that by the time they reach the 3-month outcome, any transient improvement has disappeared. We did not look for that in the trial, but I certainly have heard that from patients before where they came back and perhaps the shunt setting wasn't low enough to help them to get as much better as we would expect.
Do you know, Mark, if in the protocol was included the fact that the surgeon should be careful in avoiding any CSF drainage inserting the ventricular catheter?
It wasn't part of the protocol, but most of us do that anyway. I think that you do have some that comes out. It's not excessive. And again, there may be a transient bump of improvement. That's why the primary outcome measure was 3 months to get past that primary change that might occur.
Yeah, sure. That makes sense. And we have another question. This is from Lawrence Watkins in Queen Square. If all the randomized patients now have their shunts turned on, how meaningful will the later time points be? There won't be a comparison between treated and placebo. So we'll only be able to compare with baseline, or are some patients still switched off?
So go ahead, Mike. We've had this discussion, but yeah.
Yes, so all of the shunts are on. Almost all of the patients have reached the 12-month time point. The last few patients to enroll in the trial will have their 12-month time points collected this spring. We have just begun to analyze the data looking at 12-month outcomes. We're not at a point where I can tell you what I think it shows, other than to say I haven't been disappointed with the data that I've seen. But we have to rigorously look at the data. We have to make sure that it was collected properly, that everything is assigned to the right groups, that our statistical analysis is rigorous. But we are hoping to bring those results to the hydrocephalus conference in Sao Paulo in August.
And since the first 3 months, that was a major period where they were randomized, half placebo. We do have that baseline. If when the shunts open, we would also expect that by 12 months active shunting, they should be very similar, and that tells us a lot. And then that group combined together gives us a huge wealth of information about people who respond to shunting.
Great. Thank you very much. We cannot hear you, Mats.
Can't hear you, Mats. Nope, still no audio. Are there other questions, Giorgio?
Yeah, sure. We can go ahead. And there's another one for my dear friend Florian Volz. Considering that you had to increase the valve setting quite often, what initial Certas Plus setting do you recommend? I think this can be for you. You had some over drainage, some headaches, I think, in the PENS trial. So you can comment on that.
Yeah, well, 4 was the setting of 4 for the open group. There was a tremendous amount of discussion about that. We are not advocating 4 as the optimal opening pressure. We were trying to find an opening pressure that was going to be safe, but allow us to show a difference. And over the years, I think I've become much more conservative about where I start a valve opening pressure when it's first inserted into a patient. So thank you for bringing that up, because we do not want to be advocating everybody go put a shunt in. If you happen to be using this valve, and set it at 4 or set it at the opening pressure for equivalent valve. The rate of over drainage was compatible to other well done, especially center trials and reports, but still can be improved upon.
Yeah, and I would add to that, we did put quite a bit of discussion into the design of the study, and we're debating whether we should be setting 4 or setting 5. But what we really wanted was a setting that was sufficiently low that we would expect it to work. And I think that if you look at the percentage of patients who had low pressure headaches, for example, which is twice as much in the open shunt group as the placebo group, that 4 may be a little bit low for many patients. But I agree with Mark. We can't make a specific recommendation. There are, broadly speaking, 2 schools of thought. There are those who start high and come down low with the shunt settings, and those who start low and come high with the shunt settings. But I think the real key is that the patients must come back. You should see them. You should see their scans. You should evaluate their symptoms and their response to shunting, and then adjust the shunt setting appropriately to find a setting that optimizes their symptoms as much as possible while avoiding complications and low pressure symptoms.
Okay, I dare to try to post some questions. I'm sorry. There are a few questions regarding the design, which I find interesting. So did you have crossovers, especially from placebo to shunt? And if not, did you discuss this? This is a design that is often used.
So the design itself was a delayed start design. And that goes back to the original discussions that Jan Malm and I had about whether it should be a true crossover or just a delayed start. And I'm persuaded Jan and others that certainly in the United States, I didn't think that patients who were initially in an open shunt group would stay in the study if there was a full crossover design. They would come out of the study and then the study would not have any value. So we explicitly designed it as a single crossover. There were a handful of patients who were in the placebo group who just didn't tolerate being in the placebo group, and they switched over to open shunt. But they were analyzed as intention to treat in the outcomes there. So it was a very small number. And then with the Data Safety Monitoring Board, I think there were 2 patients who were in the placebo group who were automatically moved over to the open shunt group because the Data Safety Monitoring Board had concluded that the placebo condition was potentially harmful to patients.
Yeah, so I think of the 5 that I mentioned, 2 of them were those. So 3 others who were symptomatic enough, we had to change the valve.
I think that was a wise decision, and it touches on the ethics part, because I can imagine a patient who experiences an improvement has a very hard time to get their shunt turned off again. Do you see any ethical problems to do this study again with other? Do you expect any difference in the long-term outcome between the 2 groups? Will you look at that?
Well,
will the closed shunt group have a poorer prognosis in the long run? I'm not saying that they will, but did you?
Yeah. Well, I think that's a question to be answered, and we will have our 12-month data soon. And there are some studies in the NPH literature. Gothenburg is probably the best example that shows that delay is harmful to patients, and they may not get as much better as patients who were shunted earlier. There have been some other trials that suggested that the delay doesn't make any difference. If you look at the 3-month outcomes for gait in our study, again, there was significant worsening in the placebo group. And I think that was part of the reason that a couple of those patients wanted to change their setting. But we still need to see with the complete analysis of the data whether they catch up and stay caught up. That's the big question. And we designed the study so that we could answer that. We haven't stopped at just 3 months. We're looking at a full year's worth of outcome, and there will be much more data. What we haven't mentioned is that about 2/3 of the patients actually had a neuropsychological battery that was performed, more than these screening tests. We've not yet begun to analyze that data, but we're going to be looking to that to help to design better batteries for the future.
I think that's a very important part. Could you please expand? Jürgen is stepping in. I would like to discuss the lack of improvement in neuropsychology, for instance, and maybe also for the urinary function, which I'm convinced that you will have benefits in these areas too. So could you please comment on that? Why didn't you see any improvement in these regards?
Well, you have to think about the tools. Mark, do you want to say something?
I was going to say, to some extent we did. We weren't expecting at 3 months to get cognitive change. We all know from our practices that typically takes longer. That's why gait was selected at the 3-month mark. I think we will be following these patients out very carefully, and our hope is that they will catch up.
Yeah. And if you look at the tertiary data, again, we reported the mean and the confidence intervals. Almost all of those were in favor of the open shunt. So waiting for the long-term outcomes is important. But the other thing to remember, the MoCA or the Mini-Mental have been designed as cognitive screening evaluations, not necessarily outcome evaluations. And so there are advantages and disadvantages to using it. The advantage of the MoCA is that you can do it in clinic. It's much easier to do than a neuropsychology battery in clinic. The disadvantage is that it may not be as sensitive as other studies, which is why we added the neuropsychological testing to the protocol. And the time points for the neuropsychological battery were baseline, 3 months, and 12 months. So we expect to have very robust data for that. Jürgen, I know you're eager to say something.
Yeah, first of all, thank you so much at Excellent for this wonderful trial and the fantastic results. I would like to come back to the trial design because I think this is so essential. And you showed us that it took a decade or more to design the trial, to set up the trial. But still, I think the true effectiveness is even higher. You told us that there are at least 5 patients in the placebo group where you opened the valve before 3 months. So this is a kind of a crossover group at 5 patients in 42 patients is more than 10%. And then a second reason is because of the trial design, you have a group of patients where you did 2 CSF drainages, one for testing and one during surgery in 4 months. This is NPH therapy in many regions of the world. So probably the true effect might be even higher. Is that right? And the second question would be, from a naive point of view, probably you've been through all these discussions, why no trial design, surgery versus no surgery at all? Do you think this is unethical, or what was your reason for your trial design that you've chosen?
Let me take the last one first. And the blinding was an essential component of the study. The patients were blinded, the investigators were blinded, the research coordinators were blinded. It was only the statisticians who knew which groups patients were in. And if you do a shunt versus no shunt, and the Symphony trial was an example of that. You know, they had a delay for that. Well, the patients know they don't have a shunt, or they do have a shunt, and that influences the outcomes. So this was essential. This was the best pure design that we could think of. And there's lots of advantages to it. There's some disadvantages to it. I think that now that it's been shown confidently with this trial that surgery is effective for NPH, is going to be very, very difficult to repeat a placebo-controlled trial. I think we're going to have to look for other ways to get the data that we want.
I think the issue of CSF drainage, so they had a minimum of 4 weeks after their initial assessment before we did the baseline assessments. So often it was longer than that. And we know from experience that most patients will have cleared their effect by that time. We don't drain a lot at the time of OR, and 3 months later, that effect is washed away. Of the 5 patients who their valves in the placebo group were open, 2 of those were because of the data safety monitoring board telling us we had to open the shunts. So only 3 required opening. So it's not truly a crossover design, and we did intention to treat analysis. So I think overall it's pretty robust. I think ethically it'd be almost impossible to go back and do. I give you to do this study again.
Yeah. And the other thing to add is that there's a treasure trove of data in the supplement in the New England Journal of Medicine. And you can see alternate evaluation, statistical analyses, and so forth that may answer some of the questions that you have. You can also see the protocol details and so forth.
Mike and Mark, since the shunt setting at 8 is a virtual off, could we also say that not shunting, so put a non-functioning shunt in a patient, is harmful to the patient? So not to treat iNPH can be dangerous for our patients?
I think in the first 3 months after treatment in a non-working shunt, the patients deteriorated or didn't improve. When we open that shunt at 1 year, we'll see whether that had any long-term effect. We did the pilot with 4 months, and we thought that we had to reduce that to 3 months for this particular trial. I don't think we did any harm. And if one thing we haven't done is thank all these patients who participated in this trial, because this was an enormous undertaking and for all of them to do this with us.
Yeah. And Giorgio, if you're asking whether there's an option not to treat NPH, that's easy. No.
Oh, yeah.
There's only one option, which is if you have a patient and you've gone through the appropriate evaluations and they appear to be a good candidate for shunt surgery, there's no contraindication to shunt surgery, then you should treat them. There's very few things in the geriatric population where we can reverse them. And in particular, the gait outcomes are so important. Patients who can't walk, patients who are falling, they become homebound, they become bedbound, and that increases their morbidity and mortality. And that's what some of the work from Gothenburg showed. When there were inadvertent delays in surgery, the mortality rate was higher. These are life-changing improvements in symptoms that patients have. And they come back and they're taking care of their grandkids now. They're going out for cruises on the Mediterranean. Now, they'll come to Rome to have a vacation. So these are really life-changing improvements that we see. You can't undersell this. You can't overpromise because you never know for an individual patient exactly how much improvement they will have. But then again, longitudinal treatment, assessing the patient, changing the shunt setting if necessary, is part of that model of care.
That was exactly my point. Thank you very much.
Oops, we've lost your audio again, Mats.
Okay. I think that Mats has definitely some audio problem. Is there a specific and or mean opening shunt pressure that you would have expected to start observing clinical or functional improvement? I think we already discussed this in some ways, so I will go ahead. Yes. I think we didn't discuss this. Do you think there's a role for ETV in these patients or not?
So if we're talking about straightforward iNPH patients, not a 75-year-old who has aqueductal stenosis, the answer is no. There's a Cochrane review that says no. I have in the past, long time ago, tried this. It doesn't work. I do, however, I think it's really important to get very high resolution imaging and make sure you don't have aqueductal stenosis. If you do have it, then the issue of offering an ETV comes up. And I think my experience is that the older the patient, the more comorbidities, the less likely the ETV is going to last long term. That's the way I typically approach it.
And I think there's an important addition to that, Mark, and I agree. You need high-resolution imaging to see is there obstructive hydrocephalus or not. The interesting thing is elderly patients with aqueductal stenosis will have the symptoms of NPH, but they don't have NPH. They have obstructive hydrocephalus, and that's why the treatment option of ETV is available. And I would agree, you should start with that. If they don't get better, then you can add a shunt on top of that. But if it's what we call communicating hydrocephalus with NPH, then no, ETV doesn't work. Only shunt surgery works. Acetazolamide doesn't work. The study from Uppsala, is it Uppsala? It was presented at the Toulouse meeting and hopefully will be out in publication later this year that did not show a benefit from acetazolamide. So there's one and only one treatment for NPH, and that's a shunt.
And Zofia Chosnika is asking, have you assessed vascular morbidity in both groups?
We have the imaging, and we will be looking at that. That's in process.
How long will you plan to follow patients? There seems to be a longer-term risk for symptom recurrence that can't always be rescued by shunt setting adjustment over multiple years.
So this study is done at 12 months. All of the patients continue to see their neurologists and neurosurgeons. We're not collecting that data. I would go back to differential diagnosis, which is that it is a mistake to think that the only reason that NPH patients get worse after the shunt surgery is because of shunt failure. They're still elderly patients. They can have other disorders that are contributing to their symptoms. So you always have to step back and ask, what else could it be? Because if all you think about is the shunt and none of the other potential causes, then you're missing the opportunity to help the patient to get better. You can't exclude the shunt. You should always think about that, but it's not the only thing that you should think about.
Yeah, I would emphasize that too often I've seen people say, well, you're just getting older, your diseases are catching up with you. You really have to look at it. You have to make sure the shunt is functioning. And if you have a patient who has good quality of life and is mobilizing for a year, that's a very significant beginning. And the future will be following these patients longer and trying to validate the how long they do well with their shunt treatment, recognizing the fact that this is an older population with other conditions.
Thank you very much. Penn's trial didn't look specifically into this, but do you have any thoughts on e-shunt versus VP shunts?
Too soon to say.
Yeah, we can't really say anything at this point. They got a trial going on, the STRIDE trial, and we'll see what happens.
Okay, so.
Okay, is it time to wrap up here again? I think we have had a wonderful discussion. It's really raises many questions.
The experts here, I would like to add another question. I mean, the results are so overwhelming, and you've even shown the MRS scales briefly in your talk. And considering that you only had 50 patients in a group, this is almost as effective as a thrombectomy trial. And even if I read it correctly, even the MOCA got better. And I assume, and the zero was not included in the confidence interval. So I assume the New England Journal forced you to report it without a p-value, but I think the zero was not included. So there's even an effect in the MOCA in this very low number of patients. Is that right? And another question, you are a neurologist. I mean, the numbers of patients in the antibody trials for Alzheimer's, I think they are in the hundreds for showing a tiny little effect. And you are with 42 patients in a group on the verge of showing effectiveness with a very gross method in the MOCA, and there seems to be an effect. So don't be so humble. I think this is almost as effective as thrombectomy, the numbers you are showing us. Am I wrong, or am I missing a point?
Can I just give you a comment? Because I just checked that up. Do you know what the numbers needed to treat for thrombectomy is for large vessel occlusion? It's 2.3 to 8, so significantly higher than this.
And Mats, I'm not aware of a neurosurgical treatment that is as effective as this. Even hemicraniectomy for life-saving in malignant cerebral infarction, the number needed to treat is larger than 2. So I'm not aware of any other treatment that is as effective.
Yeah. So let me invite you to come to the American Academy of Neurology meeting and make that same statement. No, you're absolutely right. If you look at the clinical trials for the anti-amyloid treatments in Alzheimer's disease, first of all, they use this thing called sum of boxes or sum of squares for the outcome, which I don't understand, and I'm a neurologist. There's only one study I know of that looked at change in mini-mental or MoCA, and it was only after 72 months that they reported a change of 1 and felt that that was significant. Well, we've already done that in 3 months, as you said. And this is the point that we really want to make to neurologists, and Mats and I are trying to make to neurologists, which is this is a real thing. It's common. We want people to look for it. Again, as I said, they may not have NPH, but maybe you're going to find out why they're having their symptoms and get that treated or make a diagnosis. So it's really an inherent part of geriatric neurology.
Wonderful. 2 more questions. Do you now, with these overwhelming results, recommend everybody should do shunt treatment, or do you still think there's a role for specific centers? I think this is very important for the national policies.
So I think that the specialty centers are the place right now There is evidence that out in the community centers, the quality of care in regards to shunt failure and infection is higher. And I think we need to find a way to improve that. The specialty centers aren't going to be able to manage the incredible numbers of patients. So we have to find ways to up the game in the community centers. And it may be they end up handling the very simple, straightforward patients, and the complex patients come to the specialty centers. Those are all things we're going to have to work out in our individual countries.
Yeah, and to add to that, quite honestly, it's a lot of work to select somebody for shunt surgery, whether you're doing the TAP test or the ELD. And we don't yet have, a magic biomarker or blood test that will say this is the patient who has NPH and will get better with a shunt. And those are the two fundamental questions that you're asking when you see the patient. Do they have NPH, and are they going to get better with a shunt? Because there are some patients with NPH who are past the point of recovery, of meaningful recovery. And we don't know how to define those patients yet. I think a lot of community centers could handle the TAP test. They could handle the shunt as long as they have neurology and neurosurgery working together and they have a longitudinal model of care. I think it's another layer of complexity if you're doing infusion testing or if you're doing ELD. And then we can talk about the sensitivity and specificity of those tests. But ultimately, we're interested in finding less invasive, reliable, and safe ways to select patients for shunt surgery. That's the research that we're working on next.
Excellent. One last question. Now you gave us a highly effective treatment. Now give us the etiology. What's on a molecular basis or CSF dynamics basis? What's the etiology of iNPH? Just your reasoning, because you are the ones who must know it best now. What's your guess?
I don't think it's straightforward. There's more that's going to come from a tremendous wealth of data that's been collected on CSF biomarkers, on imaging. It's a CSF dynamic issue, but I think there's still the jury's out on what specific cause it is.
So first of all, it is hydrocephalus. It's a communicating form of hydrocephalus, and depending on which school of CSF circulation you believe in, whether it's bulk flow, lymphatics, who knows what, and we're still trying to answer those questions. It is a disorder of CSF circulation or physiology. And the shunt does a very simple thing. It removes some of the CSF, it changes craniospinal compliance, and then the brain gets better. And that, to me, Jürgen, is the more important question. Why is that brain getting worse? Why is that brain getting better? Because if we can find that physiological mechanism, then maybe we can design a drug to treat it or to augment the outcome. And again, I used the word dormant earlier to describe this because these aren't dead neurons or glia. They aren't ischemic. It's not that kind of ischemia. There's something about those neurons and glia that's asleep, and we wake them up. And if you ask yourself, are there other scenarios in neurology and neurosurgery where I would like to put brain cells to sleep? The answer is yes. There's a lot. It could be a neuroprotectant if we understand how it works. Now, that's speculation, and I've had that idea for more than 20 years. But the fundamental biology of the symptom development and reversible NPH is the single biggest mystery of NPH. It's all secondary to CSF circulation, but I don't think that's where the action is.
And I think the question of why do we get to the point where we have big ventricles, that's where the issue of lymphatics come in, and that's really unproven at this point.
Wonderful answers. So, Giorgio and Mats, sorry for these questions, but this was a wonderful discussion. Do you want to continue, or shall we now wrap up? All good. So thank you so much for this really brilliant and so important lecture. And we now do have a level 1 proven, highly efficacious therapy for iNPH. Thanks for that and for all your work, and thanks to all the patients. Congratulations. Wonderful. Thanks for this wonderful webinar, to the speakers, to the moderators, and of course, thank you so much to the audience and to EANS for giving us the chance to have these wonderful discussions here.
Thank you for inviting us.
Beautiful evening.
Thank you.
Thank you, and goodbye.
Bye-bye. Thank you so much. Wonderful.